evening, everyone. Thanks for showing up tonight. For those of you that don't know me, I'm Dr. Thomas Smedberg with Wisconsin River Orthopaedics, part of the group with Dr. Gallick, Dr. Dillman, and Dr. Sorensen, Dr. Walter, along with a nurse practitioner and Jennifer Conkey. So tonight, I'm just going to give kind of an overview of shoulder pain. There's a laundry list of conditions that can cause shoulder pain. We'll touch on probably just a handful of them. Otherwise, we'd probably be here beyond a well-fast midnight. Talk about everything. So, yeah, that would be a pain. So, we've been in town for decades. You don't need a referral to come and see us. Even if you're referred somewhere else, you're, as a patient, have, the right to choose, your providers. And, we'd love to take care of all your orthopedic needs. Like I said, we've been in town for years and aren't planning on going anywhere. So tonight, we're going to get started with shoulder pain. We'll go over, like I say, a handful of conditions that can cause pain, some of the more common conditions, and I'll kind of give a brief overview of each condition and then a brief management strategies and options. So the shoulder, it's the part of the body where your humerus attaches to your shoulder blade. It's got to be mobile enough to allow range of motion for you to move your upper extremity, but also stable enough to allow you to push, lift, and pull things. It consists of 3 bones. Basically your collarbone here, the shoulder blade that comes up and around here, and then your humerus, the bone of your upper arm. Let's take a snake. So here's a blow up of the bones to get that. The shoulder blade, collarbone, and humerus. Here's the front view. And the back view looks a little different from the back. And normally, obviously, you're going to have muscles attached to the bones here. So there are approximately 30 muscles that make up the shoulder complex, with the most important being your rotator cuff. A lot of pain can originate from the rotator cuff, but that rotator cuff provides stability and support of that joint. So when people are talking about the rotator cuff, basically it's 4 muscles. In the front, called your subscapularis, that's going to be responsible for internally rotating your arm, pulling it in towards your body. With the supraspinatus, the one on the top here, is probably the most frequently injured. It's responsible for lifting your arm out in front of you and out to the side. And then the 2 in the back, the intraspinatus and the teres minor, are responsible for externally rotating your arm or rotating it out. Those. Yeah. Other muscles, tendons, and ligaments in the shoulder. Again, here's your collarbone, the humerus, and the shoulder blade. You also have the bursa, subacromial bursa. That's frequently a source of pain and cause for bursitis. The biceps tendon in there. Resected here is the pectoralis major, one of the chest muscles. And in the front here is the subscapularis that internally rotates the arm. So the major joints of the shoulder, you have your glenohumeral joint. That's the main joint, the ball and socket joint. It's made up of the ball, or the humerus or the head, as well as the socket, which is the glenoid fossa. You have the acromioclavicular joint, which is the joint between the end of your collarbone and the shoulder blade. And then you also have the sternoclavicular joint, where you have the collarbone joining the chest wall or the nubia. So here's the glenohumeral joint, the ball and socket joint. It's basically like a golf tee. The socket end, it acts as a tee, the cartilage around the socket, that increases the surface area. And then you have the ball, that rests on the socket. And then you have the acromioclavicular joint. This is going to be the joint where people talk about a shoulder separation. This is the joint that gets separated or disrupted. Whereas previously, this is when people are talking about shoulder dislocations. This is where the ball comes out in discongruent from the socket. Here. And then you have the sternoclavicular joint here. Yeah, stop pushing butt here. Where the collarbone joins the chest wall. And then was all joints.
Yeah. Can you speak up just a little bit?
Okay, I'm sorry.
I'm going to dim a light a little bit.
Okay. I don't know if that would make my voice taller, though. So there are two types of cartilage in the joint. You have the articular cartilage, or the cartilage on the surface of the bone that covers the humeral head in the socket. Allows the bones to move or glide over each other. When this cartilage becomes disrupted, that surface is no longer smooth, and you develop what's called the arthritis. The joint can become painful and stiff. And then you also have the labrum, which is the ring of cartilage around the socket here. So here you have the articular cartilage. That's the smooth surface. And then as you get wear and tear on there, that gets rough, and then you get more friction there, causing pain. And then this labrum here increases the surface area of this joint to help maintain the ball on the socket. Is that better? Can you hear? Just try. So some common causes of pain we'll briefly touch on tonight. One is impingement syndrome, probably the most common. We'll talk about bicipital tendinitis, a frozen shoulder or adhesive capsulitis, rotator cuff tear, acromioclavicular joint or AC joint arthritis, and then glenohumeral joint arthritis. The glenohumeral joint arthritis is the common condition where when people say they have arthritis in the shoulder, that's usually what they're talking about. So impingement syndrome is a condition where the tendons of the rotator cuff become irritated or inflamed as they pass through the spaces of the shoulder. It often causes limited motion, pain, especially when lifting your arm. It's often associated with common repetitive overhead activities, and if not treated, can lead to further complications. So, common clinical findings of impingement syndrome: you often have pain on the anterior aspect of the shoulder, sometimes the anterior lateral aspect of the shoulder, where the supraspinatus tendon inserts of the rotator cuff. Can be acute, chronic, or acute on chronic. So here's typically what the shoulder will look like. Here's your socket. Here's the humeral head. You have the supraspinatus tendon. You can see the bursal tissue here underneath. This is part of the shoulder blade here. Here's the end of your collarbone. And to lift that shoulder, that muscle contracts, lifting the arm. Here's your deltoid muscle, the big muscle on the outside of your shoulder. But with inflammation or formation of bone spurs, you can get inflammation of that tendon or impingement, where you go to try to move that shoulder, you get friction or resistance from that tendon moving, causing pain in the shoulder. So imaging for working up the shoulder for impingement usually typically start with x-rays in the office. Also, ultrasound can be done, not as frequently because that's operator dependent, and it's typically needs to be done in real time. If you're not the one using the ultrasound, ultrasound can be much less reliable or informational. MRIs, the gold standard for imaging of the soft tissue with quite high sensitivity and specificity for impingement. So here we're looking at x-rays. On the left here's your collarbone, a shoulder blade. And if you look real close, you can see a little bone spring at the end of the shoulder blade there. And that narrows the space where that rotator cuff is tended or is passing through the shoulder, attaching on the outside of the humeral head here. You actually have a little bone spring at the end of the collarbone here. With that narrowed space, causes irritation of the soft tissue, including the rotator cuff. Over here on the right, you can see a little bone spring at the end of the shoulder blade again, the acromion. You can see some faint calcification in the bursa or the soft tissue overlying the rotator cuff here. And those can all be sources of pain. Here we're looking at an MRI. You have the end of the collarbone here. And then you have the rotator cuff passing through the space here, thinning of the rotator cuff here. This white collection here is a collection of versal fluid indicative of impingement. You can begin to see the bone spur here at the end of the collarbone, narrowing the space where that tendon is passing through, all can be a cause of irritation and pain. Here's a graphic of that. Again, you have the clavicle, the collarbone, you have a bone spur at the end of the acromion, and then you have a inflamed bursal tissue here that can get pinched as you're lifting your arm or performing overhead activities. So treatment options for impingement, the majority of them are conservative, educational, about the condition, or education about the condition, are basically, avoiding aggravating activities. Physical therapy, non-steroidal anti-inflammatory, something like ibuprofen or Aleve if you're able to. If you have conditions with your kidneys or a heart, you're going to want to talk to your primary care physician, because a lot of times those conditions will prevent you from using non-steroidal anti-inflammatories. You can also use Tylenol, but that's usually not as effective as the non-steroidal anti-inflammatories. It's more a pain-relieving effect as opposed to an anti-inflammatory. Steroid injections have shown to be a bit more effective than the non-steroidal anti-inflammatories, especially for the short term. They've done studies with extracorporeal shockwave therapy, and that hasn't been shown to be as beneficial. Typically, physical therapists will use that, but once again, it's not as effective as the injections. So other treatment, if conservative treatment has failed to provide adequate relief, usually after about 3 to 6 months, even with therapy, shoulders can take a long time to get better. It's just one of those joints where it can be slow to respond once it's unhappy. So other options for impingement are subacromial decompression, debriding the bursa. So if we go back here, we can go in here with a scope arthroscopically and clean out that tissue that can give more space to the rotator cuff here, eliminating pressure and compression of that rotator cuff, and can also take out the end of that bone spur or acromioplasty, cleaning out those bone spurs. And you can also do a resection of the acromioclavicular joint. So if you come back here, you can see use a bone spur on the undersurface of the collarbone here. So you can either go in here arthroscopically, shave down that bone spur, or shave out the end of that collarbone. That can also be done open, taking out the end of that collarbone to give more space to that rotator cuff. So here's a summary of the treatment algorithm. Physical therapy, the non-steroidal anti-inflammatory medication, corticosteroids. These two can usually be used interchangeably. And then if those are unsuccessful, then surgery usually provide benefit. Next condition we'll talk about is biceps tendonitis, which is inflammation of the long head of the bicep tendon in the shoulder. It's often caused by overhead reaching, repetitive lifting, or supination, or basically externally rotating your forearm. It causes pain in the front of the shoulder, along with tenderness along the bicipital groove where the biceps tendon runs anteriorly. This can lead, progression of this can lead to an actual tear of the biceps tendon. If it's been chronically inflamed, you get loss of flexion of the elbow or supination or rotating that forearm outward. And then if it does tear, a lot of times you'll end up with this Popeye sign where you get a ball of the bicep tendon in the arm. So here's the long head of the biceps tendon with it inflamed, fitting in the bicipital groove of the humerus. And then there's actually another attachment called the short head of the bicep on the tip of the acromion there. So if this goes ahead and ruptures, you still have this tendon that's very rarely torn, and that'll hold the biceps in place. And so disruption at long head of the biceps usually does not disable anybody significantly. Favre actually went to the Super Bowl with that tendon torn. So treatment of biceps tendonitis, the main treatment is going to be eliminating the offending activity, icing, using non-steroidal anti-inflammatories, steroid injection is an option, as well as physical therapy. So there are options for that bicipital tendonitis, and it can fluctuate and ebb and flow. Surgical treatment consists of a tenotomy or releasing the tendon, or tenodesis, where you release the tendon and you secure it to the humerus. So exercises for biceps tendonitis on the left there. The guy's demonstrating pendulum exercises where you grab a weight, like a gallon of milk. It's probably 6 or 7 pounds. You keep it close to your arm and you kind of circulate it in small circles, being careful not to get the circle too big to put further stress on the shoulder. And then you can also use biceps curls indicated on the right there, starting with a light weight, a couple times a day, high reps, to reduce the stress on the arm, and then increasing the weight, every 5 to 7 days to basically build up the strength. So here's a demonstration of the biceps tenotomy. If this tendon becomes inflamed here, typically arthroscopically, what we'll do is we'll release it from where it attaches on the glenoid or the socket, and then that tendon will retract out of the joint, and that, can result in that Popeye deformity, but functionally as a relatively limited effect on strength and motion. So once again here, the long head there that gets divided or that gets released. Often this is done with other procedures that are being done in the shoulder, whether it be a subacromial decompression that we talked about previously, rotator cuff repair, and this is usually in relatively a complementary procedure, which often goes along with things like the rotator cuff debridement or repair. And here's an example of a biceps tenodesis where that tendon is secured into the bone of the humerus. Next condition is often called a frozen shoulder. Technically, it's called adhesive capsulitis. It's a condition that's characterized by stiffness and pain in the shoulder due to thickening and tightening of the capsule that surrounds the glenohumeral joint. It results in restricted movement, It's known to be more common in women, patients with diabetes or thyroid conditions. And with this condition, patience is key because it can take up to a couple of years to improve. So it can be mentally challenging as much as it is physically challenging. So here's an illustration. Here's the capsule here. Your rotator cuff muscles will be coming over the top. So this capsule is actually underneath the rotator cuff. And you can see the thickening and fibrosis and shrinking of the capsule in there. That's going to cause pain and limited range of motion. This can be quite painful, with oftentimes the pain being more severe at night, making it very difficult for people to get sleep. So it'll go through stages, typically freezing to frozen to thawing stages. So you can have limited range of motion. It can start to tighten up and your motion is significantly limited. In severe cases, you can have a hard time getting your arm out away from your body, and particularly with external rotation or bringing your arm out. And then eventually it'll fluctuate, and usually the inflammatory process burns itself out. But the pain can be severe, and so we try to minimize the length of the process as much as we can because patients can be quite miserable. Most of the cases will resolve without surgery, but unfortunately, it can take a long period of time. So treatments for adhesive capsulitis, again, it's back to the non-steroidal anti-inflammatories, corticosteroid injection, gentle physical therapy, pool exercises. You don't want to be too aggressive with the physical therapy, as that can flare it up and make people more miserable. Once again, it usually resolves itself, but it can take, sometimes 2 years or more. Every once in a while, patients will need to go or undergo a surgical release of the capsule and manipulation of the shoulder under anesthesia, basically breaking up that scar tissue. So that can be, quite painful, but every once in a while, it's needed. So some of the exercises that people undergo to manage that, you can see the pendulum exercises similar to the previous illustration, basically kind of bending over and gently rotating that arm as it dangles, stretching the shoulders, elevating them, flexing them posteriorly or backwards, and then forcibly stretching them down, and then leaning up against the door, as well as resistance against a door frame can all help with that. Moving on to rotator cuff tear. This is probably one of the more common ones we see in the orthopedic clinic. Basically, is what it describes is a tear of the rotator cuff. This is demonstrating a tear of the supraspinatus, or the most commonly torn rotator cuff tendon. It can be partial thickness or full thickness. Approximately 60% of people 60 years old have a partial thickness rotator cuff tear. Oftentimes, partial thickness tears go hand in hand with advanced tendinitis. So those two terms can be used relatively interchangeably. And then you have full thickness tears. Those can result in weakness of the shoulder, difficulty lifting, and reaching, difficulty with overhead activities, pain at night, difficulty sleeping. When you have a full thickness tear, the chances of that healing on its own is relatively minimal. So here's an MRI of two different rotator cuff tears. So on the right here, you have a partial thickness tear. the majority of the tendon appears intact, but you do have some white signal in that tendon. It should be nice and dark and gray, kind of like it is here. As you look at the one in the left, that one's definitely more significant and likely full thickness, as this end should be attached over here to help pull that arm up, but that's torn and starting to retract. So here's a definite full thickness tear of the rotator cuff. Once again, it should be attached here, but it's starting to retract. And that's why we want to get to full thickness rotator cuff tears relatively soon, usually within the first couple months, because otherwise they will start to retract. And then getting that tendon back to where it's supposed to be can be challenging. If that tissue isn't being used in the shoulder, it'll start to atrophy and the tissue quality will start to deteriorate. And even if you are able to get it back there, sometimes if it's deteriorated enough, it can be like sewing jello together. So it can be quite challenging and sometimes unrepairable. So here's looking at directly at a full thickness rotator cuff tear. So right here you have your humeral head, and you're looking at it straight on. So there's the rotator cuff tendon tissue. And so typically during a repair, the bone here will be roughened up so it's bleeding. And then several anchors will be placed, and then suture will be passed through that tendon, and then that'll be drawn down to the surface of the bone, and that'll then eventually heal in as long as it's protected after surgery. And then once that's healed in, then you'll come out of the sling. You then start therapy to initiate strengthening, stretching, strengthening exercises. So treatment for rotator cuff tears, for partial thickness tears, again, it's going to be a non-steroidal physical therapy, stretching the tendon and muscles. Corticosteroid injection can help decrease the inflammation and the pain. And then if those fail to provide relief, you have the option of basically an arthroscopic debridement versus repair, depending on the degree of the tear. If it's a relatively minor the tear, a lot of times they'll just debride the irregular tissue. If it's more extensive, we'll usually go on to repair it. Now with full thickness tears, if it's repairable, we try to repair those surgically as often as we can, because those will usually progress and become worse, making it difficult to repair later. And it can also lead to instability of the glenohumeral joint or the ball and socket joint. The balls start to move up in the socket, and if it moves up high enough, you can actually rub on the ulnar surface of the shoulder blade there. So if it's unrepairable and the patient isn't able to tolerate surgery, non-steroidals, physical therapy and injection are all options for pain relief, but that won't solve the underlying tear. If that tear becomes unrepairable and the patient is able to tolerate surgery, there is an option or a reverse total shoulder replacement, where the replacement provides stability to the joint, and then the deltoid, or the big muscle on the outside of your shoulder, is used to move your shoulder. But the goal of that surgery is mainly pain relief. It's not necessarily function gaining surgery, and the expectation is to get your arm to about shoulder level without pain. Anything above that is basically icing on the cake. So here's basically a demonstration, or just a schematic of a rotator cuff repair using arthroscopic tools, using the small incisions. Here we're passing suture through the tendon, and then they'll put anchors in that bone there, and then secure that tendon down to the bone, and then allow that to heal. So again, here's a schematic of a reverse total shoulder replacement. And the reason they call it a reverse is if you look at the humerus here, typically you have the ball on the humerus, and then you have the socket here. in this surgery, when the ball gets cut off with a saw here, and then the ball gets moved to the socket side, and then you basically put a socket on the humeral side, and so the ball and socket are being switched around. And then your deltoid muscle, or the big muscle on the outside of your shoulder, is the one that is mainly responsible for moving the shoulder in that case. And this is the reverse total shoulder replacement can be used in a number of situations. One of them being in the situation where the rotator cuff is unable to be repaired. And then it can also be used in a situation for shoulder arthritis where the rotator cuff isn't in good functioning condition. Next condition we'll talk about is acromioclavicular joint arthritis. So this is a degenerative condition where you have arthritis at the end of your collarbone, where it joins the shoulder blade. We can lead to pain, stiffness, limited range of motion of the shoulder. A lot of times it's going to be the result of wear or tear. As you get older, if you've done activities with your upper extremities or done physical labor, a lot of times you're going to develop arthritis in this joint. However, it's usually much less symptomatic than if you develop arthritis in your glenohumeral joint or the ball and socket joint. So a lot of times we'll see, wear and tear of these joints on x-ray, but oftentimes it's not typically symptomatic. So here's your ball and socket joint, the glenohumeral joint, and then you have your acromioclavicular joint. So you can see the bone spurs at the top and bottom of that collarbone there, bone spur at the top of the shoulder blade, and then this space is narrowed compared to what it normally should be. So in this condition, a lot of times the pain is located on the top of your shoulder. It's pretty point specific. The small bump on the end of your shoulder, which is often palpable and sometimes visual or visible. You can, is the location where that pain is. It typically, tenderness of that joint, difficulty with lifting activities or reaching across your body, such as putting on your seatbelt or activities like that. So treatment for that is typically non-steroidal anti-inflammatory. You can inject that joint with corticosteroid, and you can also take out the end of that collarbone so that space isn't so narrow, and that can be done either arthroscopically or open, either way. But a lot of times, like I said previously, you're going to see that wear and tear on the x-rays or the MRI, and a fair portion of the time it doesn't need treatment. Now we're on to kind of the final condition we'll talk about. That's is going to be glenohumeral arthritis, or basically shoulder arthritis, and this is typically the arthritis that people are going to be referring to when they have say they have shoulder arthritis. It's characterized by breakdown of the cartilage surface of the ball and socket joint. And so if you crack onto the end of a chicken bone, this would be nice and white and smooth. That's how the cartilage should look when you're looking directly at it. But as it breaks down, it's going to get rough. It's not going to be smooth. You're going to have a lot of friction there, and that's going to cause pain and inflammation and stiffness in the joint. So here's an illustration of what the glenohumeral joint or the shoulder joint should look like on the left. And then on the right, break down to that cartilage. You're going to get bone spurs depending on the degree of degeneration. And those bone spurs, it can be quite significant. And in severe cases, you can basically, for lack of a better term, develop a square peg in a round hole. So here we're looking at x-rays. Again, here's the end of your collarbone, your shoulder blade. Here's the socket here. It's kind of difficult to see, but basically this humeral head is round. The surface is nice and smooth. You're going to have space in between the ball and the socket. As that wear and tear progresses with arthritis, we're going to have that bone spur at the bottom of the humeral head. The humeral head will become irregular, and then you can also get bone spurs on the socket or the glenoid, and that space eventually decreases, and you'll develop a bone-on-bone arthritis. So treatment options for a shoulder arthritis, you're going to get the options of injections, which are going to reduce the inflammation, decrease the pain. Shoulder arthroscopy is an option, although it's relatively used rarely, just because the results are going to be temporary. You can shave the loose cartilage flaps and smooth some of the bone spurs, but the relief is usually short-lived and less predictable. So although it can be used, it's not used very often. And then the definitive treatment is going to be a shoulder replacement. And the longevity of that replacement is going to be, affected by your activities. Usually it's recommended avoiding heavy activities afterwards, as that's going to increase the wear and tear and decrease the longevity of the joint. So here's an illustration of the shoulder replacement. You have the prosthesis that goes down the humerus along with the humeral head, and then usually this glenoid component or the socket component is heavy duty plastic, and those surfaces are smooth, and obviously there was no nerve endings in there, and so that goes a long way in terms of alleviating the pain and the friction in the joint. And so as we saw previously, here's a reverse total shoulder replacement where you had the ball and socket switched around. And this metal is usually a specific type of metal that allows bony ingrowth and stabilizes the components in the bone. And this is going to be used in conditions where the rotator cuff isn't functioning like it should. So when it's an MRI, when we see an MRI like this where there's a tear of the rotator cuff that's retracted and atrophied or shrunken down, and looking at this tissue, we can tell the quality of that is not very good and isn't repairable. A lot of times this is going to be a situation or where a reverse total shoulder replacement is warranted, because in a regular shoulder replacement, you need the rotator cuff to come over the top here and hold that ball in place. And so on the reverse, based on the constrictions of the implant itself, the rotator cuff isn't really required. And so it's relying on the restraint of the prosthesis to hold it in place and provided it's functioned. And so here, this is just a comparison of an anatomic total shoulder replacement next to a reverse. So you can see the differences with the ball and the sockets that was switched around. And, each shoulder replacement, has its specifications that are required for it to function appropriately. And this is what it's going to look like on X-ray. You can see it's typically going to be a plastic component, but you can see the metal of the component here on the socket. And then we have the prosthesis going down the humerus and the humeral head. And then these are going to be sized appropriately to attention the rotator cuff in the soft tissue intraoperatively. And then here's what a reverse total shoulder replacement is going to look like on X-ray. You can see the screws and going into the socket, and then the prosthesis and the humerus, and then we have a piece of plastic here. Oh, and then here's all three, the comparing in. So that was relatively brief, but it was basically an overview of common causes of shoulder pain. And so, I thank you for taking time to come out tonight. And, if anybody has questions, I'm happy to take them, comments. Yeah.
Is it true that a rotator cuff can heal itself?
If you have a partial thickness tear, now if you go, let's see here, if we go back for lack of a better illustration, if you have a tear like this will not heal on its own, because this is basically like cutting a rubber band. So if you cut that rubber band, that muscle, basically when a muscle functions, it can contract and relax. But if it relaxes, there's no way to physically get that end back there. So it's going to contract, and it's just going to keep moving that direction. Now, if this is a partial thickness tear where you still have the component that's attached there, that can gradually heal with time. Well, a full thickness tear can't heal on its own. And so that's why with a full thickness tear, we like to get to those relatively soon, because it's going to continue to contract. And then it's going to atrophy because it's not being used, because it's not attached on long enough.
What's the process of that arthroplasty? What is that? How does that surgery work?
So with that surgery, what we do is we typically make an incision in the front of the shoulder. And let me go back to the rotator cuff. So looking at the front of the shoulder, typically what we'll do is make an incision on the front of the shoulder, and then you make an incision. Unfortunately, there's no good way to get into the shoulder joint without disrupting this tendon. And so you go through there, we make an incision in that tendon, and then with the replacement, we'll cut off the ball, and then that prosthesis is going to go down. We ream or broach, or basically pound in prostheses of increasing size. Prostheses of increasing size until you get a good fit with the bone. And then we'll also ream the bone on the socket side, and we'll size that socket so you get an appropriately fit socket. And then that'll be secured on the socket side. And then we'll select, there's different sizes of the sphere for the humeral head. And then we'll size that appropriately. And then we'll kind of reduce the shoulder, and then we'll kind of assess the stability in there.
What you mentioned that doesn't last a long time.
If you're lifting heavy weights or you're hard on it, you'll wear it out. But the goal of that is that should be able to last for, 15, 20 years if you're doing light activities.
Because they're light. I've had both mine done. And they call it they call it arthroplasty. They cut subscapular bicep. Went in, dislocated it, and then shaved off whatever arthritis was on the humeral head, and then the cup side as well. And then they titaniumed the ball. Is that the same thing?
Yep.
Okay.
That would be
arthroplasty.
Arthroplasty, replacement. Those terms are kind of interchangeable.
Okay.
So based on what you're describing, that would consist of a shoulder replacement.
So now I still have, I would say, 90% of the pain is gone, and my range of motion is 90%. And as he says, it's never going to be 100%, but at the same time, when it was only 20%, I guess it's 90% pretty good.
We're not perfect.
I know. As much as I'm like, I'm very happy with it, but
but he lifts weights. He goes to the gym
Yeah.
a lot, and he is a big gym rat. Is this not good for him?
No, it depends. You don't have you lifted heavy weights. Light weights, high reps. Yeah, keeping those hustles strong, but not trying to set the gym record.
No,
On isn't going to be the goal. That'll wear them out quicker.
and I still feel pain. Advil takes care of it pretty quick, and it's really not an issue there. And
Yeah, and unfortunately, it's not going to be your normal shoulder. It is a replacement, and so the goal is to try to get you a joint that functions, with as minimal pain as possible.
okay, and he advised that rather than a full shoulder replacement, just because of activity.
So it sounds like you may have sometimes what they call a ream and run, where they'll replace the humeral head.
Yeah.
But they'll just kind of ream the socket, not put a glenoid component in there, because those are notorious for somebody that's very active. A lot of times that those components can loosen. So if you're going to be lifting weights with a shoulder replacement, with further information, it probably sounds like you had what's called a hemiarthroplasty.
Yeah, that's exactly yeah.
They put the humeral prosthesis in, but they smooth out the surface of that socket, but they don't put a plastic component or a metal component in there, because if you're doing things like lifting, that's going to increase your risk of those components loosening, and then if those are loose, that's going to cause increased pain, and then you're likely going to need a revision. And so without a glenoid components in there, it's probably, from what you're describing would be the appropriate surgery, because you're going to be active, and that, you're using it, and you are getting some discomfort, because that socket surface isn't resurfaced. But those, those replacements or those prostheses are allowing you to remain, quite active.
Yeah.
And go to the gym and push your limbs. Life is why. Yeah.
Is a shoulder replacement an outpatient procedure? And then what is the typical therapy afterwards?
Typically it's an outpatient procedure. The majority of the patients will go home the same day. Now there are some patients that require an overnight stay. But in terms of physical therapy, typically you're in a sling or in a mobilizer for a couple weeks, and then we get you going in therapy, usually outpatient therapy. And then, recovery is going to be anywhere from, 3 to 6 months, getting the majority of your range of motion and your strength back. Sometimes, if you're getting all your strength back, then you're probably going to talk about, being a 6 to 12 month recovery. But with that longer recovery, that doesn't mean you're not doing anything for that period of time. It just, in terms of getting the last percentage of strength and range of motion, can sometimes take the longest. Yes.
A reverse shoulder replacement and I have a torn and a lot of arthritis. Is it ever to the point where you can, like you said, a square peg, and I wonder that is it.
It can make it more challenging when it gets, you get osteophyte formation or bone formation where the humeral head deforms so much. Sometimes it can be quite challenging to perform the procedure. But in rare cases, if you get so much wear and tear of that socket, and it becomes flat or deformed so much that, it can be difficult to get bony purchase with the components. But that's relatively rare.
Yes.
But it is possible. I mean, sometimes people, will have so much deterioration of that socket, there's not much left to hold a component in there, bone-wise.
Bone-wise.
Then, unfortunately, a lot of times it's going to be hatching out. But I wouldn't recommend now. But then you're back to basically, you're going the wrong direction here. But we're back to the conservative options, where, if it's unrepairable, then you're going to be back to the non-steroidals, the physical therapy, and the injections. but they're going to be less reliable. But obviously it's not surgical, but depending on your activity level, those are options, but it's not going to solve the underlying problem.
If you still can raise your arm and you have torn rope, is that a good sign?
Yeah. I mean, you can, there are people that, every once in a while we'll get construction workers in, where they're kind of, they're willing to kind of stubborn and are willing to work through the pain. And, they're able to get their arm up here, but their deltoid or the big muscle on the outside of the shoulder is doing the majority of the work and are having pain. And so, if you have a full thickness rotator cuff tear, and your pain's manageable,
Lunar, it's not the full, I really don't know. I don't think it's a full, but I tried to look at those MRIs again and try to figure out what's a full and what's a tear about. I can't do it. I'm not good enough. But I still had hope that that's mending something.
It's not likely to heal, but, if you have a pain-free shoulder and you're able to do the majority of your daily activities, then it becomes, basically a decision in terms of do you, undergo the risk of surgery and lose range of motion, but decrease your pain.
Yeah.
And you're kind of weighing, the options. And so sometimes that can be, something you got to take a little bit of time to think about,
And just I wear compressions, something around my shoulder thing, and that seems to help a lot.
And that's perfectly fine.
I wear it all. I wear it all the time now.
A lot of times people with rotator cuff pain are going to have pain on the outside of their arm because that pain refers there.
Yeah.
And, you may have a little bit of bicipital pain. And if you're able to get by with a compression sleeve and you're able to do the things you want to do, and I would say, I'd probably continue with that as long as you can.
I have it days. I had good sleep and good bad sleep.
With a lot of us.
Yeah, Jim. Everybody here knows that. But the thing, and there's no staying, like, I'm by myself, regardless away. There's no staying in a rehab center.
And typically people don't go to a rehab center, but, everybody's social situation is different, and so, and those are all factors that are going to weigh into, decisions that you make.
Say I went to a different hospital and he said, got a reverse shoulder replacement. And I explained the thing. I'm all by myself, 75 years old. Could I stay in the rehab for just a week even? I have insurance.
Or full clinic.
Or I don't even want, I want.
And well, in this day and age, unfortunately,
They don't do that.
they don't do it. And unfortunately, it's going to be the tail wagging the dog in terms of the insurance companies that have a lot more pull. Could we get you into, a rehab facility? We could, but then, it's going to need to be full disclosure that, the insurance company could stick you with the bill.
Yeah.
And it's just like, when you're 3 weeks down the line and you're doing better and you're at home, but you have a huge several $1,000 bill from your stay in the rehab facility, you're going to forget about that shoulder pain, and all of a sudden that pain is going to be, your pocketbook,
Well,
and most people, but, could we get you in a rehab facility? We could, but
it is paid over in the hospital for a day.
usually you can stay overnight. Usually that's an option. And, if you're in a sling and your pain's relatively managed, the majority of people, with, preoperative planning, can plan appropriately and can do, quite well.
I don't what time does sound like you need a second OPIC?
But I was told, and the doctor was probably a very good doctor. He said, you are even going to need you're going to be up and going and I not, what did you say? How much? Like you're in, no, I was going to be up and going in a couple days.
Yep. I mean, you're going to be up and moving around, but we have to we have to kind of protect that rotator cuff repair. With that sling.
Hand, I can't, you're not driving or.
No, that could be challenging. I mean, in terms of if you can't drive.
Well, but that's my own problems.
I was just wondering about if now and there's a lot of arthritis. There's a lot of arthritis through my whole body.
This one has a lot of arthritis in there. So has it gone too far?
Not likely. I can't, speak specifically. Just obviously, I haven't seen your imaging, but, there's always a small possibility where, it can go too far, but those cases are relatively rare.
You know what? Just today, I was sorting through paperwork and there was images of my shoulder and I ripped them up.
So, it's good news. I mean, we still have x-ray machines.
Yeah.
We can always do it anyway.
I care less about an x-ray.
But it's the outpatient. I heard your clinic does some of those things, or is it in a hospital?
Nope, it's at our surgery center. We have the capability of overnight stays, 23-hour stays. And so the a lot of times, when we need to go to the hospital, it's for medical reasons. With patients, she has the cardiac issues and things like that, but we do have the capability of keeping people overnight. So,
If you've had multiple partial rotator cuff tears, does that make you susceptible to some of these other problems?
it can, with the partial tears, they can eventually, develop into a full thickness tear. And with the increased, laxity in the joint, that can increase the wear and tear of the cartilage. And then, you're at risk for developing arthritis. And a lot of these things are going to go hand in hand, like bicipital tendonitis, partial thickness tears of the bicep tendon are a lot of times going to be seen, in conjunction with rotator cuff tears or other things like that. Or, the bursitis or impingement, and there's going to be, kind of a whole spectrum of that you often, rarely do you see, an isolated rotator cuff tear with no bicep tendonitis or arthritis of the acromioclavicular joint. A lot of times, we see, that type of arthritis, but the majority of the time we don't have to do anything about it. So. Well, thank you, everyone. Thank you. Appreciate you coming out. Hopefully you were able to get, a little bit of information. And, if you guys, have any orthopedic needs, we're always here to take care of you. Thank you.